All right, everybody. I think I'll go ahead and get started and people can join as they come in. Welcome. Happy Friday, everybody. You are joining our Grand Round clinical section that was rescheduled. We're very happy to have you here today. Housekeeping, we are recording this session and we will be archiving it on our foundation website under the following link you see on your screen, and CMR is also attaching that into your chat box. We will have questions and answers after each presentation, so please feel free to unmute at those times or type your questions into the chat room and we can read them all. Please sign in for your attendance to claim your CME or CE through EEDS text messaging method or the website portal using the sign-in code that we're going to provide you in just a second. After completion of the sign-in and evaluation, you will receive your certificate. Please also complete out the evaluation survey that will be sent to you post-program, which is required to get your certificate and provides us with great feedback. So here's the information to collect your CE. This is for a half a credit today. The activity sign-in code is 38TINT, 38TINT, and the code will expire tomorrow at noon. So please use the sign-in methods you see on the screen to go ahead. You can sign in right now. I think the sign-in is on the chat box currently, so you can take a minute to do that. Event disclosures today is Priyanka, Rana, and Mohammed Waseem have no relevant financial relationship to report in the last 12 months with a commercial interest, and this activity is not commercially supported. So quickly, next week on February 10th, we're going to start a new series of CME programs. Self-kindness, we're going to go back to some resilience training that we had done last year. Different programs, but we really hope you enjoy this. And I believe the link to sign up is coming into the chat room, and we will be sending out emails. All right, so let's get started. The role of contralateral extremity X-ray in the diagnosis of fractures and trauma in pediatric patients. And the PI facility is Metropolitan, and we're going to take it away with Priyanka.
Hi, my name is Priyanka. I am an undergraduate and I'm also a research volunteer in the Metropolitan Hospital Center. And my topic today is the role of contralateral extremity X-ray in the diagnosis of fracture after trauma in pediatric patient. So trauma to the extremities is common cause of pediatric emergency department visits. After conducting a detailed history and physical examination, the providers will order diagnostic X-ray scans to rule out the fractures. So extremities injuries has been a common problem in pediatric practice. The utility of bilateral extremity X-ray in pediatric patients to compensate for the presence of growth plates has been frequently been called into question. Our literature review has suggested the limited utility of bilateral X-ray. In fact, the American College of Radiology, ACR, has only recommended for the use of hip X-ray. X-ray overutilization is costly and lengthen examination time and ED X-ray. Additionally, it can also prolong harmful radiation exposure to staff who have to stabilize children for the scan. It is customary in most departments to order a bilateral extremity X-ray in a setting of trauma to the extremities. So the objective of the study is to evaluate the utility of contralateral extremity X-ray in the setting of extremity trauma in children younger than 16 years old. We also investigated if the presence of a contralateral extremity image helps successfully identify fractures in the affected limb. We hypothesized that the imaging of the affected site should be sufficient in children with extremity injury. Imaging of the contralateral extremity does not add much information. We reviewed the charts of patients who received extremity X-ray after trauma. The patients were selected from the picture archiving and communication system PACS using the referring unit as the emergency department, and the study modality is a diagnostic X-ray. The time period selected was from August 1st, 2019 to July 31st, 2020. Charts were reviewed for the site of the injury, fracture location, and for the presence of comparative contralateral extremities X-ray. And gender and age were also recorded. The radiologist X-ray report was studied to determine if the fracture was diagnosed with the aid of the contralateral X-ray. And interpretation was made by obtaining anteroposterior and lateral comparison views of the normal site. All comparison views were put aside until a report of the affected site has been made. So if a comparison view was considered necessary for the conclusive diagnostic, radiograph of the unaffected site were then studied and recorded. Any changes in the previous diagnostic were also noted. Medical record of each patient were reviewed correspond to the accuracy of the clinical program. So a total of 82 patients under the age of 16 years old were enrolled in the study. 46 patients had only one-sided imaging, and the remaining 36 had bilateral imaging. Figure 1b shows the distribution of no-sided comparison X-ray by age, with patients older and younger than 10. Of the 46 patients who had a fracture identified with one-sided imaging, 29 patients, or about 63%, were below the age of 10 years old, and while 15 or 37% were above the 10 years old. So figure 1c shows the distribution of bilateral imaging. 78% of the patient or 29% were younger than 10, while 22% were older than 10 years old. So the graph shows the distribution of the comparison on genders. 51 were male and 30 were female patients. 62% and 38% respectively. Figure D, E, F, G shows the distribution of one-sided and bilateral imaging with genders. Higher percentage of bilateral imaging was also performed with patients younger than 10 years old, 60% and 81% of males and females. So here is a table that sums up what we talked about the graph on the previous slide. The results were summarized with the incidence of fracture by anatomical areas such as hands, ankle, foot, forearms, and wrist. All of the pathologies of the patient who received comparative extremity imaging could have been diagnosed without the contralateral image. So radiography is a proven and useful procedure for evaluating bones, joints, and soft tissues of the extremities. It is often the first study to be performed for evaluating pathology of the extremities. Imaging an extremity is essential for identifying fractures. Identification of the fractures helps the provider to decide whether to choose a comparative or a conservative management. In children, the presence of growth plates makes it challenging to distinguish between fractures and growth plate gaps. At the same time, increased radiation exposure had adverse effect on the children. The cost associated with several films is also important to many parents and guardians. Selective use of comparison views is more cost efficient, and it delivers less radiation to patient and personnel compared to obtaining the routinely in all cases. Obtaining views of both extremities and by using the normal side as a baseline for the comparison also helps to increase the confidence in the initial reading. So in conclusion, the results of the study suggest the imaging of the affected extremity is sufficient to make the diagnosis of the fracture. The majority of fracture could be identified in our studies using imaging of the affected site. If needed, we can make a limited use of comparison views. However, minimal delay in diagnosis and treatment when a comparison view is requested should not lead to a significant increase in the fatality. Here are my references. Thank you.
Wonderful. Thank you, Priyanka. Does anybody have any questions? That was a great presentation. You can unmute yourself and ask a question, or you can type it into the chat box and we can read it off for you. Anybody? Okay, you did a great job, Priyanka.
Thank you.
Okay, next presentation. The application of procalcitonin to febrile children in the emergency department. This was done at Lincoln, and Dr. Waseem will be our presenter today.
Good afternoon. My name is Mohammed Waseem. I'm a pediatric emergency physician at Lincoln Medical Center in the Bronx, New York. And today I'm going to talk about my research project regarding application of procalcitonin in the evaluation of children who present to the emergency department with fever. So my research team include Michael Castro, Davami Rosario, Jesse Vandale, and Paul Fields. This team also included support from St. George's University. One of my author in this presentation is Michael Castro, who was a fellow from St. George's University. So when you work in the pediatric emergency department, you see a lot of children who present with fever. And many times you don't have a source of fever, and it is difficult to determine which children have bacterial infection, which children has viral infection. And it caused a challenge is to categorize that which children are at higher risk for serious outcome or serious bacterial infection. And based on physical exam, it is difficult to detect or identify children. However, the recognition of serious illness and its timely recognition and identification is very important in order to prevent the poor outcome. The evaluation of febrile children remains variable. So we conducted this study in which we used the procalcitonin, which has emerged as a biomarker to determine a distinction between bacterial and viral infection. Procalcitonin may serve as a marker for invasive infection, and also it correlates with the severity of the disease. The purpose of this study is to evaluate whether procalcitonin can be utilized in the decision-making of children who present with fever to the emergency department, and also to assess whether procalcitonin can be used to help identify serious bacterial infection in children who present with fever. This is a retrospective study which was conducted at Lincoln Medical Center, ED, which is a busy place, and about 40,000 children are seen every year in this emergency department. The study duration was from January 2018 to 2019, and our population of interest was children between 3 to 36 months. We use the cutoff 3 months because in younger children, there are different recommendations are used for their management. And the fever cutoff is 102.2, and in children who have procalcitonin level also available, those are the population of interest. So we identify children based on their discharge diagnosis, whether they have a confirmed bacterial cause or a confirmed viral cause. And then we compared procalcitonin, CRP, and WBC level to those diagnoses. Our reference values are for procalcitonin more than 0.5 nanogram per ml, CRP more than 0.5 milligram per deciliter, and WBC 19,000. Our confirmed sources or confirmed diagnoses include bacterial causes, occult bacteremia, UTI, meningitis, and confirmed viral causes include RSV or influenza infection. As you can see that 73% of children in confirmed bacterial have a level more than 0.5 nanogram per ml. However, in confirmed viral causes, only 46% has a level above this threshold. When comparing bacterial versus viral causes and procalcitonin level, this box plot shows that more than 70% of the data in the bacterial group is above the threshold of 0.5, with the p-value is 0.001, which is very significant. In terms of CRP, If you compare the bacterial and viral causes, both group has their data above the threshold of 0.5, which make this distinction or this threshold ineffective in distinguishing bacterial and viral cause. In terms of white blood cell, this box plot shows that almost all data is below the threshold of 19,000, which makes this cutoff very ineffective. So in conclusion, procalcitonin level has a moderate level of accuracy for determining serious bacterial infection in children who present with fever. It appears to be superior to CRP and WBC, but the diagnostic accuracy can be improved when you combine this with CRP or other acute phase reactants. Since this is a small study, done only a small center, we need more studies or a larger study to determine its utility over traditional laboratory screening tests for serious bacterial infection. So how we can use this data to our clinical practice? Procalcitonin level can help to reduce the number of unnecessary use of antibiotics in children with fever. And of course, it will help to decrease the antibiotic resistance. On the other hand, children who are really sick or have sepsis, you can avoid a delay in antibiotic administration. These are my references. If there is any questions, I'll be happy to answer. Thank you.
Excellent, Dr. Waseem. Thank you so much. Any questions for Dr. Waseem? Please feel free to unmute yourself or type your question into the chat box.
Hello, my name is Wajiha. I'm one of the Pediatric Emergency Medicine Fellow. My question to Dr. Waseem is that how long does it take for the procalcitonin result to come back? And what is the cost difference between CRP and versus procalcitonin?
So in our, thank you for your questions. In our center, CRP is sent out. We don't get CRP on the same day, but procalcitonin result is available in a couple of hours. I don't know about the cost about this, means how much it cost, but the turnaround time is very quick, is about with at least less than 2 hours.
Thank you.
That's a great question. Thank you, Dr. Saeed. Any other questions?
Sorry, one question more. So depending, were you able to look at the data set for those patients, depending on procalcitonin, those who had more than 0.5, they got antibiotic versus those who had just increased CRP values?
This project did not look at what the patient received. This project was evaluating whether procalcitonin level can distinguish between the bacterial cause versus a viral cause. So the project started with the final diagnosis, and we go back and see what was done in those patients. We did not look what the treatment these children received. We look at the distinction between the bacterial and viral cause based on procalcitonin.
Thank you.
Speaking as a layperson, is there a reason not to do pre-calcitonin? Would it be good to do it for every child that comes in?
I mean, this is a quick test, and if the child has fever and the source cannot be identified, I think it is reasonable to do this test in every child with fever.
Thank you. Any other questions? Wonderful. Okay, that was fantastic. Thank you. I'm just giving you a reminder, putting the screen back up. To get your CEs, please sign in with 38 TINT by tomorrow at noon. And the codes are listed on your screen there. We will be putting this whole program up in our archives, and you will be receiving, I think you've already received the link, but we will send it out again. Thank you so much for your attention today. Please join us next Wednesday for another Grand Rounds. Have a wonderful weekend.